Hello, Dr. James Alexander, psychologist here, and today I'm wanting to talk to you about the little known science of pharmacogenomics, sometimes also called pharmacogenetics. And I call it the little known science because in my observation, very few psychologists have ever heard of it, even fewer members of the public have ever heard of it, and even very few prescribers, GPs or psychiatrists have ever heard of it. And pharmacogenomics has very important implications for how individuals respond to psychoactive substances, which include the whole gamut of substances that affect our brains. Recreational substances such as alcohol, cannabis, party drugs, amphetamines, etc., hallucinogenics, right through to fairly benign substances like nicotine, caffeine, etc. But also, very importantly, prescription drugs, primarily the psychiatric prescription drugs such as antidepressants, benzodiazepines or minor tranquilizers, major tranquilizers, mood stabilizers, etc. Antipsychotic drugs as well. So pharmacogenomics is the science of the interaction that occurs between a person's genetically determined ability to metabolize, break down and expel psychoactive substances and the effect and those substances themselves. So everybody's probably noticed in their lives, you may very well have friends or family members who seem to be able to drink enormous amounts of alcohol, as an example, or smoke copious amounts of cannabis and barely seem affected at all. We've also noticed friends or family members that seem to be able to only have tiny amounts of alcohol or tiny amounts of cannabis and be extremely adversely affected for a long period of time. So it's the same substance. However, what we would notice would be a very large variation in the differences in how people respond to the same substances. Some people seem to have very little, if any, tolerance towards substances, whereas other people seem to have a great deal of tolerance towards exactly the same substances. And of course, the same is true when it comes to prescription psychoactive substances. There are some people who swear by the benefits of antidepressants or benzodiazepines or whatever. And there are other people who equally honestly say that those same drugs nearly killed them and they should be made illegal. Neither people are lying, they've just got extremely different experiences to exactly the same substances. So how can this be? How can the one substance lead somebody to report that it feels like it saved their lives, whereas exactly the same substance can lead another person to report that it feels like it nearly killed them, and neither people are lying. So clearly there's an extremely large variation in terms of how different bodies react and how different brains react to exactly the same substances. I'm sometimes misperceived as being anti-psych drugs, and I prefer to think that I'm not actually anti-psych drugs. I'm not anti any drugs in that I'm a libertarian. I favour the idea that people should have the right to put whatever substance they choose into their own body and take responsibility for that. I am very much in favour of informed consent. My concern is in the Western world, where psychiatric drugs are prescribed, there's very little informed consent, in that most people are not terribly well informed by their prescribers about the potential adverse effects, the potential for what appears very much to be like addiction, the potential for finding it very difficult to come off the drugs. So my experience, my observation is that very few people are very well informed about all those potential downsides of prescription psychiatric drugs. My purpose and my goal in regards to psych drugs is to simply see more people be able to offer more informed consent, which means that they need to be better informed. And the study of pharmacogenomics is one excellent way of informing people about what is actually going on. So my intention today is to give you a bit of a thumbnail sketch on what pharmacogenomics is all about. I only learnt about it probably 10 years ago, I think it was, by listening to a particular health program on a particular radio station in Australia. Had I not been listening to the radio at that particular time, I don't think I would have any awareness of pharmacogenomics, because as far as I know, it hasn't hit the popular media. Very few people have ever heard of it, although I do know that the Australian government is currently putting millions of dollars into researching the potential benefits of pharmacogenomics. So clearly people in positions of power and responsibility are aware of the value of this field of study, but as yet it has not filtered down into the general population, and in my experience it hasn't yet filtered down to the prescribers either, which I think is very unfortunate. So in order to function with psychoactive substances in our system, our body needs to be able to break down and expel the chemicals in those drugs. And the process of breaking down the chemicals in the drugs is referred to as a metabolic process. And once the chemicals have been broken down, they get expelled through our urine and faeces. Now, there's a particular family of liver enzymes called the CYP450s. And my impression is there's quite a lot of liver enzymes in that particular grouping. But the focus of the studies tends to be around 6 particular liver enzymes. There's only one grouping of liver enzymes, so there's many other liver enzymes that have other functions. But the particular function of the CYP450 family of liver enzymes is purely to break down and expel psychoactive substances from our system. The amount of these particular liver enzymes that we've got, the CYP450s, is genetically predetermined. So because we inherit 50% of our genes from our mother and 50% of our genes from our father, their loadings of the CYP450s ends up being reflected and genetically given to us. So of the 6 different liver enzymes that are regularly tested for, we may be high in one of those particular liver enzymes, low in another one, medium in another one, extremely low or totally absent in another one, etc. So across the 6 different relevant liver enzymes, we have varying loadings or amounts of those particular liver enzymes. And how much of a particular liver enzyme that we've got pretty well determines how we're going to react and how our brain is going to react to a particular psychoactive substance. So for example, when it comes to, let's say, alcohol as an example, the person who seems to have no ability to tolerate any alcohol at all, one glass or half a glass of anything, they're going to be drunk, severely drunk, and drunk for quite a long time, it's very likely that that person has virtually 0 of the required liver enzyme needed to break down and expel ethanol, which is the chemical in alcohol. Whereas the person at the other end of the continuum, the person who can drink and drink and drink and hardly ever seem affected, is more than likely a person who has been born with an abundance of that particular liver enzyme. So the alcohol barely touches the sides with them. Their body is able to break it down, and expel very quickly. And as a result, there's a relatively low concentration of ethanol in their blood supply adversely affecting their brain. Whereas the person that has virtually 0 amounts of the required liver enzyme for alcohol, there's a very high level of concentration of ethanol in their blood supply because their body is very unable to break down and expel the ethanol. So it builds up a higher level in their blood supply, which goes to the brain and then adversely affects the brain. So they get drunk, get very drunk quicker, and they tend to stay drunk for longer. So what's true for alcohol is also true for every psychoactive substance that you can think of, including cannabis, nicotine, caffeine, amphetamines, hallucinogenics, etc. The people that can cope with a lot of these different drugs and not seem terribly badly affected have simply been born with a large loading of the required liver enzyme to break down that particular substance. And as a result, their body's able to expel it quickly, it doesn't reach a high level of saturation or concentration in their blood supply, and doesn't have such a large, profound impact on their brain. What's true for recreational substances is also entirely true for prescription psychoactive substances. So here we're talking about psychiatric drugs. As I said before, this includes all the different types of antidepressants, SSRI antidepressants, for example, Prozac is the best known of those, MAO inhibitor antidepressants, tricyclic antidepressants, benzodiazepines, Valium is the most well-known one of those, also known as minor tranquilizers, antipsychotic drugs, mood stabilizers, etc. All these drugs, like alcohol and cannabis, because they're psychoactive, they affect the functioning of our brain, need to be broken down and expelled by these particular liver enzymes. As with the example of people that have different levels of liver enzymes to break down and expel alcohol, exactly the same thing applies when it comes to prescription psychiatric drugs. Some people have been born with virtually none of that required liver enzyme, whereas other people have been born with an abundance of that required liver enzyme. Typically, my reading of the research suggests that when people report very positive responses to psych drugs, for example, antidepressants, my guess is that they've been born with full loading of that particular liver enzyme required to break down that particular antidepressant. And as such, they're not going to experience adverse effects, and therefore a full placebo effect is more likely to be able to function. If you don't think placebo effects are largely responsible for the reported benefits of antidepressants, then I suggest you read a book called The Emperor's New Drugs by Irving Kirsch. I think it's about 5 years old now. And Irving Kirsch did he's a professor of psychology in America, he did a lot of research with the clinical trial data that the drug companies collect when they're assessing the efficacy of psych drugs, antidepressants, etc. And he demonstrates through his statistical analysis that psych drugs are essentially, when they work, or antidepressants, which is what his book is primarily about, when they work, it's primarily due to an enhanced placebo effect. So, the people that report a beneficial effect from antidepressants, and clearly there are people that report that, are more than likely getting a beneficial effect. It may simply not be because of the reasons that they've been told, and it may be more to do with the placebo effect, to which I've got absolutely no argument and no problem. If people get a placebo effect and it's beneficial, great, no problem whatsoever. The problem is that for every person that reports a beneficial effect, there's another person that reports an adverse effect. And again, as with the example of alcohol, pharmacogenomics and the role of these specific liver enzymes has a great deal to play in these different outcomes. So for every one different type of antidepressant, there's one particular liver enzyme that's required to break down that specific antidepressant. And while it's breaking down it's responsible for breaking down that particular antidepressant, it's also going to break down a bunch of other psychoactive substances. And each of these different liver enzymes in the group of the CYP450s has different substances that they're responsible for breaking down and expelling from the body. And different antidepressants will be broken down by different liver enzymes. So when a person reports adverse effects from a particular antidepressant, then it's very likely that their system simply doesn't have the loading of the particular liver enzyme that's required to adequately break down and expel the chemical in the drug from their body. And as a result, the concentration of the chemical in the drug builds up in the blood supply and ends up adversely affecting the brain. And when people are adversely affected by antidepressants, unfortunately, the adverse effects include worsening depression, increases in suicidal ideation and feelings and behaviour, increases in anxiety and panic attacks, increases in emotional instability, poorer sleep, and a whole raft of other physical side effects that tend to go along with it as well. Some people can even be brought to a drug-induced psychosis from antidepressants. And again, it may be the same antidepressants that for another person is felt to be highly beneficial, and they feel that they're so good that these drugs should be in everybody's drinking water. However, the exactly same substance can take another person to suicidal despair, anxiety, panic, and even psychosis. If you look at the rates of reports of adverse effects, the literature suggests that anywhere between 30 and 60% of people taking antidepressants, particularly SSRIs, selective serotonin reuptake inhibitor antidepressants such as Prozac, anywhere between 30 and 60% of people report adverse effects, depending on the source of literature that you're reading. Some sources of literature that I've read suggest that the adverse effect rate is closer to 100%, depending on how you define adverse effects. But the standard literature seems to suggest anywhere between about 30 to 60%. The drug companies admit to around 30% of people on SSRIs experiencing adverse effects. Other literature suggests it's closer to 60%. So if you take a stab somewhere in the middle, you're talking around 50% of people that are quite likely to experience adverse effects. And that means that they're going to get worse rather than better as a result of being on antidepressants. And unfortunately, people that are already depressed have very little room to move with their emotional well-being. If any substance is going to interfere with the small amount of emotional well-being that they've got left remaining, then that effect can be really quite devastating for people. Professor David Healer, Professor of Psychiatry in Britain, wrote a book called Let Them Eat Prozac, in which he reported he had also done the statistical analysis of the full data sets that the drug companies had kept hidden, that he got access to through Freedom of Information Acts. And he suggested his statistical analysis indicates that the rates of suicidality actually increase as a result of people going on to SSRI antidepressants rather than decrease. And that would be simply because maybe around 50% of people are not able to adequately metabolize, break down and expel the chemicals in the antidepressants, and therefore all they're getting is not a placebo bounce but adverse effects. And if they're already close to the edge, it can be just the straw that breaks the camel's back that pushes them over the edge. So Professor Healy suggests that his research indicates an increase in suicide rates as a result. And indeed, if you look at the suicide rates that have increased all over the Western world in the last 30 years that SSRIs have been on the market, and have, I think the rate of antidepressant prescription has gone up by around 500% during that time frame. The suicide rates have also gone through the roof in the Western world during that time frame. So there may be a causal relationship between the increased prescription of antidepressants, particularly SSRIs, and increased suicide rates. And pharmacogenomics is likely to be the explanation as to why that is. So, in regards to any one of these particular liver enzymes in the CYP450 family, we all fall into one of four categories, depending on the loading of liver enzymes which our genetic inheritance has given us. Some people are born with basically none of that required liver enzyme, and these people are referred to as poor metabolizers. So this is the person, when we're talking about alcohol, if they have even half a glass of alcohol, will become adversely affected quite powerfully and very quickly, and stay adversely affected for a long time. When we're talking about antidepressants or other prescription psychiatric drugs, if the person is a poor metabolizer, if they've been born with virtually none of that required liver enzyme needed to break down and expel that particular drug, then this person will experience pretty profound adverse effects quite quickly. I've had clients that have told me within the first couple of hours of taking only one antidepressant, they've had diarrhoea, vomiting, shaky, dizzy, unable to stand up, etc. Clearly they've had an extremely bad, violent adverse reaction. And that's simply because their body has none of the required liver enzyme needed to break down and expel that particular substance. And as a result, it reaches a high level of concentration in their blood supply very quickly, and it goes to the brain where it adversely affects their brain. Despite having profound adverse effects, I don't tend to worry too much about these people, because by and large they can easily recognise that despite the reassurances, this drug is a poison to me, and they tend to flush them down the toilet and put them in the rubbish bin. So as a result, they tend not to stay on the drugs, and within a matter of days the adverse effect will pass and they won't be continuously putting in a substance into their body which generates an ongoing adverse effect. So they're the poor metabolizers. The next group of people are called the intermediate metabolizers, and these people have been born with a semi-loading of the required liver enzyme, which means we could call it, let's say, roughly a 50% loading, which means they've got some capacity, their body's got some capacity to break down and expel the substance, but they also are lacking in some capacity to break down and expel the substance. So these people are not going to have the violent adverse reaction as the first group. And in fact, they may not get any adverse reaction at all for some time. But within a time frame, could be anywhere between a few months to a few years, because their body is somewhat unable to break down and expel the chemicals in the antidepressant, it means that the chemicals are slowly, bit by bit, building up in concentration in their blood supply, and over a period of time reaching such a concentration that they end up adversely affecting the brain. And again, when that happens, the adverse effects look like worsening depression, suicidal feelings and ideation and behaviour, anxiety and panic attacks, emotional instability, etc. Often the exact reasons why the person went on to the antidepressant to begin with. So part of the problem is that the adverse effects will often mimic the poor state of well-being that the person was in, which led to the prescription being made to begin with. So that's very unfortunate. The other very unfortunate thing about this is that with this second group, the intermediate metabolizers, there's a time lag between when they first started taking the drug to when they start experiencing the adverse effects. And because of that time lag, most people don't put one and one together and recognise, aha, I'm being adversely affected by the drug. They don't think that because they've been on the drug for months or a couple of years, and they actually felt better at the beginning for the first several months or a year or two, probably because of the placebo bounce that they got from it. And it's only some time later, months or years later, that their emotional well-being begins to go down bit by bit until they're back to where they were beginning. And they don't recognise that this is probably an adverse effect of the drug. So unfortunately, this group of people I do worry a lot about. They tend to go back to the prescriber, a GP, which is more common than a psychiatrist, but either will tend to do the same thing. They go back to the prescriber, and generally the prescriber suspects that this is a reoccurrence of the initial depressive problem, and what do? They increase the dosage level, which is about the worst thing that could possibly be done for this person, because their body and their brain is already not coping with the amount of the substance, the amount of the drugs and the chemical already in their system. And so the worst thing that they can do is to increase the dosage level, which makes it even harder for their body and their brain to cope. But this is the typical response that most prescribers do when they're confronted with a person that's been on the antidepressant for quite some time and comes in reporting that they're actually now feeling worse, not better. Unfortunately, not only do prescribers increase the dosage level, I've had many clients in which the prescriber has put them on an additional antidepressant, or an additional mood stabiliser, or an additional antipsychotic, or a benzodiazepine. And so this person's body and brain is already not coping with the amount of work, the metabolic work that the CYP system has to do in order to clear the body of the chemicals in the drugs. And so the worst thing that can happen for these people is that more and more drugs keep on being added into the mix. But that's typically what happens. And so this person is likely to come away from their consult with the prescriber with either an increase in the prescription of the original drug and or 2 or 3 additional drugs thrown into the cocktail. And unfortunately for these people, what I've seen happening is sometimes a rapid or a gradual deterioration over time. They tend to plummet downwards and downwards and downwards. Their emotional state gets worse and worse and worse because their body and their brain is simply not coping with the amount of drugs that's now required to metabolize, break down and expel. The concentration of drug in the blood supply is building up and up and up, and the increased adverse effect on the brain is just intensifying as time goes on. And these people tend to get worse with time, not better. I sometimes see these people 5 or 10 years down the track when they're now on 4 or 5 different psych drugs. And generally they're a mess, and they've been a mess for a long time. The prescribers don't know what to do. They just keep on piling in more drugs, or it seems like a merry-go-round of different drugs because there's a seemingly endless array of different psych drugs that the people can be put on, and so they try one drug after another, after another, after another, after another, and it's all very much just Russian roulette that unfortunately doesn't help people to get out of the problem that they're in. An American psychiatrist called Peter Breggin, who I suggest you look up online and read as many of his books as you can. He's written, I think it's something about 30 books over his long career as a psychiatrist. One of the great books he wrote is called Your Drug Might Be Your Problem. And it's a very relevant and important book for people that are on a bunch of different psych drugs, or even just one psych drug, and seem to be getting worse, not better. Although Peter Breggin doesn't talk about pharmacogenomics, he talks about the whole raft of adverse effects, and more importantly, what people can do in order to try to peel back the amount of drugs that they're on and do it safely, and try to get back to having as close to 0 psych drugs in their system as they possibly can while they're getting psychological support and help, which is often quite necessary. Okay, so the second group of people, the intermediate metabolizers, tend to get worse over a period of time because their body is somewhat failing to fully break down and expel the chemicals in the psych drugs. The third group of people are called the adequate or the normal metabolizers. And these people have been born with the full loading of the liver enzymes required to break down and expel the particular drug that they are on. So quite simply, their body is up for the job. And because they're not likely to experience adverse effects, they're more likely to get a positive placebo bounce out of the drug and therefore report that they're doing quite well on it. The final group of people are called the ultra-rapid metabolizers, and these people have been born with an abundance of that particular liver enzyme. So normal prescription levels are barely going to touch the sides with them. These people are not going to experience adverse effects. So if you look at the ultra-rapid metabolizers and the normal metabolizers as being people whose body are capable of breaking down and expelling the drugs, and if we lump those two groups together, and if we lump together the poor metabolizers and the intermediate metabolizers, people that are likely to experience adverse effects, and we separate them into these two groupings, it's about a 50-50 split in the population. And that roughly accords with, if we take the median point between the statement of 30% of people experiencing adverse effects from antidepressants and the reported result of up to 60% experiencing adverse effects, then we're talking again, it's about a 50-50 split in the population. So it's basically a toss of a coin as to which of these two groupings any of us are likely to wind up in. I might also add that which of these groupings that we are in has no other adverse implications for our state of health. We can live a perfectly healthy life with being a poor metabolizer or intermediate metabolizer or ultra-rapid metabolizer. It makes no difference to our general state of health until we put into our body particular substances that those specific liver enzymes are needed to break down and expel from our body. So there's no other health problems attached to this genetic inheritance that we're all carrying. It only really matters when we start putting psychoactive substances into our body, whether those be recreational drugs or prescription drugs. A note on recreational drugs. I've seen people being just as easily brought undone psychologically by alcohol and cannabis as I've seen people being brought undone by adverse effects from psych drugs. And again, the people that are brought undone by drugs like cannabis and alcohol are poor metabolizers and or intermediate metabolizers. If they're putting a lot of that substance into their body and their bodies has a very limited capacity to break down and expel that substance, again the substance builds up and up and up, the chemical builds up and up in their blood supply, and the ethanol or the THC will adversely affect their brains. I've seen clients in the part of the world that I live in, people are often strong advocates for the medicinal benefits of cannabis, and I have no argument with that where research indicates that there are medicinal benefits to cannabis. However, one of the problems is that THC, which is the psychoactive substance in cannabis, again, we're all going to respond differently to THC. Some people have no ability to metabolize, break down and expel THC, while some people have a limited ability, some people have a normal ability, and some people have an extreme ability to break down and expel THC. And it's the people that have the zero ability or the limited ability, the poor metabolizers or the intermediate metabolizers, have limited ability to break down and expel THC. The THC is going to build up in their blood supply, adversely affect their brain, and when that occurs, then there are people that I've worked with that have gone psychotic. It's called a drug-induced or a toxic psychosis, as opposed to what's called a functional psychosis, which happens in the absence of drug effects. So toxic psychosis occurs in the presence of an excessive amount of substance use over a period of time, and the psychosis is just as real. So people can have delusions and hallucinations and be highly agitated and highly distressed, and unfortunately they will come in contact with the psychiatric system. My observation has been the psychiatric system seems to be very poor at differentiating between functional psychoses and drug-induced or toxic psychoses. They lump them all into the same category, and typically they'll call them schizophrenic or psychotic in some form, and they'll put them on antipsychotic drugs. And again, one of the problems for these people is that their body is already struggling to expel psychoactive substances from their system, and the brain's being adversely affected. Simply putting them on different psych drugs runs the risk that those drugs are also not going to be adequately expelled from their body. They're going to build up in concentration and again just adversely affect their brain. And I've seen some clients be very badly affected by that happening, and it's a very unfortunate thing. So while I think everybody's got the right to put alcohol or THC or hallucinogenics or psych drugs or any substance they choose into their system, as long as they're willing to take responsibility for the outcomes, no substance, whether it be alcohol, cannabis or anything else, is universally safe, and that's very clear. They are not safe for everybody. So the advocates for decriminalisation of cannabis tend to proclaim that cannabis is a universally safe substance, and I can guarantee you, like all substances including alcohol, it is not universally safe. There are some people for whom it is a dangerous substance simply because their body doesn't have the metabolic capacity to adequately break down and expel the THC. So that's a side issue. Back to prescription drugs, particularly antidepressants. which have become the most prescribed psych drugs in our society, of course. I think in Australia it's about 1 in every 10, no, I think it's 1 in every 20 people in Australia is on an antidepressant. No, 1 in every 20 is on a psych drug, more people are on an antidepressant. In America, I think it's about 1 in every 10 people are on a psych drug, on an antidepressant, whereas about 1 in every 5 or 1 in every 6 is on a psych drug. So the study of pharmacogenomics and the explanation for adverse effect of psych drugs is a really important topic for so many people in our society. So when a person is an intermediate or a poor metabolizer or an intermediate metabolizer of psych drugs, as I said, the chemical will build up in the blood supply, adversely affect the brain, and the person winds up having more and more adverse effects, worsening depression, suicidal ideation feelings, self-harming behaviour, anxiety, panic attacks, emotional instability, poor sleep, a range of different physical side effects, and in some cases manic type responses, which is usually misdiagnosed as being evidence of bipolar disorder, which then attracts different drugs being put into the equation. And other forms of psychosis, again, it's a toxic or a drug-induced psychosis. A person can become fully psychotic and exhibit symptoms that look like schizophrenia, again, delusional belief systems, hallucinations, etc. And obviously these are very poor outcomes. The problem is that the cause of the very poor outcome is usually unrecognised. And this is the importance of the science of pharmacogenomics. It brings in a reason that explains why some people have these extremely bad outcomes from psych drugs, which other people may not have such bad outcomes too. The adequate metabolizers and the poor metabolizers are not likely to experience these adverse side effects. Now, the story gets a little bit more complex. If it was as simple as just the inherited loading of these specific liver enzymes, then that would be clear and a slightly easier situation. However, it's a little bit more complex than that. The response that any one individual has to a particular psych drug or any particular psychoactive substance is only about 75% related to the loading of liver enzymes that we genetically inherit. The remaining 25% is explained by exposure to environmental toxins, which then have an impact on this metabolic system. I'm not a biologist, so I don't understand how it has that impact or in what form it does. I simply know that it does have this impact. So, environmental toxins, what are they? Back in the days that car petrol had lead in it, then car exhaust was rich in lead. And if kids grew up in an inner urban environment, then there was a high loading of lead from car exhaust in the atmosphere. And it's known that lead is an environmental toxin which adversely affects the physiology. So that's a really good example of an environmental toxin. It's no longer in our petrol, and so therefore the concentrations of lead in the atmosphere are far less than what they've ever been for a long time. So that's not going to be highly relevant. Certain industries have high levels of exposure to environmental toxins. So people working in agriculture, through herbicides and pesticides, spraying of herbicides, cattle dips and sheep dips where they're exposed to high-powered pesticides. Again, they're examples of environmental toxins. Jewelers, silversmiths who work with molten metals like silver that exude toxic gases, they're exposed to environmental toxins. I've never read anything about this, but my guess is that people that work in dry cleaners may very well be exposed to environmental toxins just by the pungent smell that I've often detected when I've been in a dry cleaner's shop. I'd be surprised if there weren't environmental toxins coming from the substances used there. And there would be a whole range of other kinds of exposures to environmental substances in our society. So I imagine they tend to be largely industrially related, but some of them are probably ambient, just in the atmosphere, probably more likely to be in urban environments. I remember reading or hearing that brand new cars exude, the fabrics used in brand new cars and the glues exude toxic gases. So that's possibly another exposure to environmental toxins. Glues used in modern housing, again, exude gases that may very well have toxic elements to those. So if people have had a large exposure, probably through working in particular industries, to environmental toxins, then that will also have an impact on the body's ability to break down and expel psychoactive substances. And so the remaining 25%, which genes can't explain, is explained by these environmental toxins. The story, when it comes to Ssri antidepressants, the story gets even a little bit more complex. And that's simply because Ssri antidepressants are unique amongst psych drugs in having the capacity over a period of time to hamper the functioning of the very liver enzyme that is required to break down and expel that particular drug. So of the 6 different liver enzymes that are tested for in commercially available genetic tests, which I'll talk to about shortly, one of those particular liver enzymes is responsible for breaking down and expelling this particular antidepressant. Let's call it Prozac, simply the most well-known of the SSRIs. Research has demonstrated that over a period of time, and again it could be months to years, Prozac will have a negative impact on that particular liver enzyme's capacity to do its job. It will begin to hamper and decrease that liver enzyme's ability to break down and expel the Prozac. And what that means is that the liver enzymes, the genetic inheritance of the liver enzymes locate us in one of each of these 4 categories. It locates us in being either a poor metabolizer, intermediate, a normal metabolizer, or an ultra-rapid metabolizer. But if the drug itself, when we're talking about Ssri antidepressants, have the capacity to hamper the functioning of these liver enzymes, it means that the ultra-rapid metabolizer can be reduced to the functional status of a normal metabolizer, and they'll still be fine. They're still not going to experience adverse side effects. But the normal metabolizer will be reduced to the functional status of the intermediate metabolizer, which means that over a period of time, months to years, they will experience adverse side effects. And the intermediate metabolizer, over a time, will be reduced to the status of a poor metabolizer, the functional status of a poor metabolizer, which means that they will experience adverse side effects. So everybody can be moved down one functional status on their capacity to process, metabolize and expel Ssri antidepressants. And so rather than being a 50-50 split in the population, it begins to look more like that. It's only really the ultra-rapid metabolizers that are ultimately going to be not adversely affected by the functioning of the drugs, whereas everybody else has been reduced to a functional status where it's predictable that they're likely to experience adverse effects in varying degrees. For some people that will be catastrophic, for some people it will be milder. Now, there are genetic tests that can very simply and easily take a sample of your DNA, either through an inner cheek test with a cotton bud, which you then send off to a pathology lab where geneticists then analyse the genetic data. And the report that they provide will tell you, from a genetic perspective, which of these 4 categories your genes have landed in, and what's the loading of each of, let's say, the 6 different liver enzymes that they test for. What's your loading of genes from a genetic perspective into each of those six different liver enzymes. So on one it might say that you're a poor metabolizer, on another it might say you're an intermediate metabolizer, on another one it might say you're a low normal metabolizer, on another one it might say you're a normal metabolizer, on another one it might say you're a rapid metabolizer, on another one it might say you're, again, low, etc. Okay? So it will give you a very detailed report about where your genes have landed you in regards to those particular liver enzymes. And it will tell you, typically they provide a table in the report of all the different commonly prescribed psychiatric drugs and which liver enzyme is required. Often there's 2 required to break down and expel that particular drug. And it will match up your genetic profile with those tables, and it'll tell you which drugs your system will not be able to cope with, which drugs you can reasonably expect to experience adverse effects from, and which drugs your system should be able to cope with. Now that's great. That's really important information, apart from when we're talking about Ssri antidepressants like Prozac. And of course, the reason being is that Ssri antidepressants have the capacity to reduce us all one functional status. So genetically, I might be a normal metabolizer, adequate for metabolizing Prozac. And if I get a genetic report, which then reports back to me that says, yep, no problem, Prozac within normal prescription levels should be fine for you, I think, great, I can take Prozac. However, how I respond to Prozac is going to be only 75% dictated by my genes. The remaining 25% of how I respond to Prozac is going to be dictated by my exposure to environmental toxins. Now, Prozac must, like all Ssri antidepressants, because they adversely affect the metabolic system, must be considered an environmental toxin. If I'm genetically quite okay, I've got all the required genes, loading of the right gene in order to process and metabolize, break down, expel Prozac, but after 6 months or 12 months or 1 year or 2 years, Prozac has stopped that liver enzyme from doing its job well enough, that will reduce me to the status of being an intermediate metabolizer. And I can then expect to experience adverse side effects some months to years later. And the problem, as I said before, is that because the onset of adverse effects is not related to the time in which I took the drug, when I started taking the drug, there's a great time lag between the two. And because so few prescribers have ever heard of pharmacogenomics and are unaware of this phenomenon, it's quite likely that my prescriber is going to increase the dosage level of Prozac because it appears that I'm simply having a reoccurrence of depression again, and or throw in a benzodiazepine like Valium in order to settle down my anxiety. May also throw in a more powerful mood stabiliser like Xanax. And depending on how bad I am or how responsive I am to the increased drugs or the additional drugs, or how worse I continue to get as I unravel, may very well put me on an antipsychotic as well. So I can wind up being on 2 antidepressants, a benzo, a mood stabiliser and an antipsychotic. And I'm continuing to get worse and worse and worse and unravelling and unravelling and unravelling as time goes on. So you can see that can be a very poor outcome. Now I might have had a genetic test that said, you're fine, you're a normal metabolizer, you should be able to cope with Prozac just fine. But of course the genes are not telling me anything about the other 25% of the equation, which is my exposure to environmental toxins. I may have grown up in an inner urban environment where car exhaust was full of lead in the 60s and 70s. I may have worked as a silversmith at some time in my life, or as an agricultural labourer around cattle dips or in a tannery. I may have had that exposure, or it may just simply be the exposure to environmental toxin is in the form of me taking Prozac, which then hampers the functioning of the required liver enzyme. So a genetic test I think if somebody's considering going on to any psych drug, it's a really good idea. It's going to give you really important information so that you are far better equipped to make an informed decision and offer your informed consent about going on to any psych drug. However, you need to keep in mind that when it comes to Ssri antidepressants, it's going to fail to tell you about a really important 25% of the equation, which adds into predicting your outcome of being on that drug. So in the interest of people being able to offer informed consent, my goal is that people become well informed. You can look up pharmacogenomics online, also known as pharmacogenetics as another search term. In Australia, where I live, My DNA is a commercial product. It costs, I think, around $120. I think it's well worth getting. I've had quite a few clients that have undergone the assessment and received the report, and I've been able to help them to analyse the report and make sense with their GP or prescriber, make sense of what the report is suggesting for them. And it provides really valuable information as long as they remember the remaining 25% of the outcome which our genes can't explain or predict. It's a very important caveat. So it does provide important information as long as people remember that factor. So My DNA have a very good website. Anybody in the world can access Google My DNA, and it will bring you to good information for customers about pharmacogenomics. It also has very good pages on their website for prescribers, for psychiatrists and GPs. If your prescriber doesn't know about pharmacogenomics, I'd suggest that you inform them about it and suggest that they have a really good read of what's on the My DNA website. No doubt other countries around the world have similar commercial products that are available. So I strongly urge people to get this test. If you're considering going onto a psych drug, then I would suggest it's a really important thing to do to learn about your pharmacogenomic profile before going onto a drug. If you really feel the need to go onto a psych drug, then I believe you should have the power and freedom to do that unharassed by me or anybody else. I would simply urge you to get the genomic test done so that you can then have a very good idea about which drug your system is likely to cope with and separate those from the drugs that your system is not likely to cope with. Without being informed by pharmacogenomics, your experience of being on psych drugs like antidepressants is going to be far more like Russian roulette. There's no science involved in that. It's simply give it a go and see what happens. Most people that are depressed enough that they are seriously contemplating going onto psych drugs don't have the room to move. They don't have the room to have a bad experience with Russian roulette. If they get worse, being even just a little bit worse from an adverse effect could push them over the edge. So I'd really suggest that people don't do that. Don't go onto a psych drug without first getting a pharmacogenomic test. It's a little bit of money. It can be hard to find a spare $120. But that little bit of money is a far cheaper option for you than getting onto a drug that your system simply can't cope with and being brought undone progressively by more and more of the drug and more drugs being thrown into the equation as you unravel, as you become worse and worse. Nobody needs that. Nobody's going to benefit from that. It's a very expensive, both emotionally, psychologically and financially, it's a very expensive downward trend for a person on that trajectory. And it's to be avoided at all costs. Final thing about pharmacogenomics, keep in mind if you are on any kind of psych drug, your metabolic pathway is already busy breaking down and expelling the substance. Even if you're genetically you are inadequate or an ultra-rapid metabolizer, there's still a workload on your metabolic system to break down and expel the chemicals in the drug that you're already on. If you then add into the equation other drugs like alcohol or cannabis or amphetamines or hallucinogenics, recreational drugs, then you're increasing the workload of your metabolic system. And a fair analogy to take with this is, imagine if that's a normal freeway, let's say you've got 4 lanes on a normal freeway and all the traffic's able to move through very easily and quickly. If that gets reduced down to 1 lane because of roadworks, okay, but you've got 4 lanes of traffic trying to get down and through 1 lane of roadworks, then obviously there's going to be a lot of congestion, a lot of build-up of traffic. And it's exactly the same with psychoactive substances. If our body's already working hard to break down and expel a prescription drug, and we throw other psychoactive substances into our system like cannabis, like alcohol, then it can be like that freeway going down from 4 lanes down to 1 lane, and the congestion then builds up. And the congestion in your body is a congestion of the unprocessed chemicals that your body is yet to metabolize, break down and expel. Therefore, they're building up a high level of concentration in your blood supply, which goes to your brain and adversely affects your brain. And when that happens, toxic psychosis can occur. So I've had clients who have been on antipsychotics and have been taking and getting adverse effects from antipsychotics. My guess is that they're poor or intermediate metabolizers of that antipsychotic. And in order to quell down the adverse effects from the antipsychotic, they've used cannabis as a way of settling down their central nervous system. And of course the cannabis will have the desired effect. In the short term, it settles down their central nervous system in the quantities that they were taking. It acts as a central nervous system depressant. And so rather than feeling agitated and anxious and uptight because of the adverse effects of the antipsychotic, they start to feel calm and relaxed, and therefore they stay using the cannabis. However, they've got this 4-lane of freeway traffic going down onto 1 dirt road phenomenon happening. And over a period of time, I've seen such people, the congestion that builds up in their blood supply adversely affecting their brain and putting them into toxic psychosis, which then gets misdiagnosed as being a functional psychosis. They get called schizophrenic or bipolar or whatever it might be. They tend to be locked up against their will, and they tend to be forcibly treated with antipsychotic drugs, often injected with ones that last several months at a time. So that congestion keeps on being added to and added to and added to. And unfortunately, they've unwittingly played into that as well through trying to settle their system with cannabis or alcohol or whatever it might be. So people need to be really aware of this happening so as to prevent it. As I said before, it's very expensive. It takes a huge toll on people. It really damages their self-concepts and their belief in themselves. And it damages their lives and their prospects in life to go down that psychiatric path unnecessarily when it's often drug-induced. And, or at the very least, the adverse effects have added to that downward trajectory. And it's to be avoided, and often it's highly avoidable. And information is what tends to help people to avoid that. Okay, one final thing I'd like to say about the prospect of using antidepressants. As I said before, Irving Kirsch wrote this fantastic book called The Emperor's New Drugs, where he talks about and clearly demonstrates the beneficial effects when they occur from antidepressants, particularly SSRIs, as resulting from what he called an enhanced placebo effect. Research very clearly shows that the vast majority of depressive episodes that people experience are very time limited. They tend to last, the majority of them tend to last a matter of weeks up to a matter of a couple of months. And then things have changed in the person's life. They've come to some different realisations, some different conclusions, some different resolutions about what they're doing or how they're going about living their life, or external circumstances in their life change. And the vast majority of episodes of depression then self-resolve, or the people have managed to resolve the episodes themselves. Research very clearly shows that. The majority of depressive episodes self-resolve. And what that means is that if most people do nothing other than just wait, you'll come out of it. Therefore, being on antidepressants is usually not required. The research evidence suggests that most episodes of depression are referred to as being mild to moderate. The research also shows that antidepressants have no demonstrable effect, no demonstrable positive effect at all on mild to moderate episodes of depression. Research shows that most antidepressants are prescribed for mild to moderate episodes of depression, which the research shows that antidepressants have no beneficial effect for. When people report beneficial effects from antidepressants, it tends to be because they're inadequate or an ultra-rapid metabolizer, so they're not getting an adverse effect, and therefore the path is cleared for them to get a placebo bounce, which is very real, and the benefits are very real of that. So I don't have any argument with that, as long as they're aware that over a period of time, an SSRI is going to drag them down in their metabolic status to a lesser functioning status. Depression is not an illness like a flu that you can catch. The medical conceptualization of depression often talks about it as though it's a medical illness that people get. Again, I keep on referring back to research which has been abundantly clear in this regard that I'm about to mention right now for decades, about 7 or 8 decades. What the research shows very clearly is that depression results from an experiential context. It comes from our lived experience of adverse life events, often traumatic, sometimes maybe not severe enough to be called trauma, but still adverse life events. And in particular, adverse life events experienced in childhood. So the more adverse, what the research shows in abundance, is the more adverse life events somebody experiences in their childhood, the greater the chance they have of experiencing depression in their adulthood. And what that means to me is that depression is not an illness. It's not a thing that exists in its own right. It's a relatively normal human response, a very unfortunate one and a very painful one, but a relatively normal human response to trauma and adverse life events. Now, it can be trauma and adverse life events from our past, so it can be historical trauma and adverse events, or adverse life events going on now, so current stressors in your life, and or a combination of both, which is not at all uncommon. And typically, when people are carrying the burden, a psychological burden of historical trauma or adverse events, and combined with current stressors in their life, unresolvable problems that just go on and on and on, often the consequences of that is simply too much for the person to cope with. Their coping resources are therefore overwhelmed. We sink into a state of hopelessness and despair, and our culture has come to call that depression, as though it's some kind of illness that people just get and therefore require drug treatment. I don't believe it's an illness. I don't believe it's a thing. I think it's a normal human response, and sometimes it's an extremely painful and debilitating and powerful human response that will derail people's lives, and I've certainly worked with many people that fit that description. So I'm not playing it down. I'm not suggesting that it's just a little aspect of life. It can be an overwhelming and a life-changing aspect and an unrelenting aspect for some people. But to me, what that means is that in order to overcome this normal human response to adverse life events, we need to do two things. We need to address the stressors that are going on in our life now and try to ameliorate them in whatever way we possibly can. So we need to engage in active problem solving. And that might mean changing our job or reducing the hours of work that we're doing or increasing the work that we're doing. It may mean changing the nature of what's going on in our relationships or changing the relationships. It may mean addressing medical conditions that have been outstanding or other sources of stress in our life that have been going on in a chronic manner. It may mean any of those things, and it's going to involve problem solving. Now, sometimes we can really be aided in our problem solving by getting professional help. Quite a bit of research evidence shows that if a GP is willing to engage with you in problem solving discussions, that can be highly effective. So it doesn't have to be a trained psychologist or a counsellor or a psychotherapist. It could be a friend or a family member or somebody trusted in your life that's able to take you through problem-solving conversations and help you to orientate yourself towards solving the problems that have been unrelenting. So that's one aspect of what we need to do. And the second aspect of what we need to do is that we need to address the historical trauma and adverse life events. We're carrying this burden of distress, and we have been for years in our life, which unknowingly to us is pretty well pulling our psychological strings and our emotional strings. It's dictating the flavour of our emotional and psychological lives. And you may have watched my other videos, EMDR Explained 1 and 2. If you haven't seen those, I'd suggest you do watch those, because my career in psychology brought me to EMDR therapy as the main tool that I use for helping people to work through their historical trauma and adverse life events. And as a psychologist that's been practicing for more than 30 years now, I'm still yet to see anything that is more effective than EMDR. Unfortunately, there is no magic bullets in life. I don't think anything is going to work for everybody. It's probably horses for courses, and it could be the right thing at the right time, and people are at different stages in their journey of distress or their journey of historical trauma and dealing with that. And sometimes it's a matter of the right thing at the right time. But I'd strongly urge people to look into EMDR. There's not only my videos on YouTube about EMDR, there's a whole bunch of other ones that have popped up in the last few years. There's an abundance of information out there. There's an abundance of research evidence that even though EMDR is odd, and it appears to be odd, it gets fantastic results for the vast majority of people, which involves not only people that have got a one-off trauma in their adult life, but also involves really good outcomes for people that experience complex chronic trauma from adverse life events that are historical going back into their childhood. And with those complex developmental trauma from childhood experiences, the intensity of the distress is often greater than it is for one-off traumas. The length of time that a person's life has been dictated to by the complex trauma is longer, and therefore it's more established, and usually that's going to require that we have more perseverance in working with the complex trauma scenario. We may need to work with more experiences over a longer period of time. But my observation of people, many people that have been willing to do that, is that if they do persevere, they stick to the process, and we work through these experiences systematically, typically they get excellent results and outcomes. So I'd urge you to have a good look at EMDR, have a good look at pharmacogenomics, look up online, look up My DNA, which is a capital M, small y, capital D, capital N, capital A. Look that up online. And get the help that you need in terms of problem solving. And if you're able to cover those, then there's a really good chance that you will actually get better and you'll stay better. If you want a written description of pharmacogenomics, then I'm happy to email that to you. You would simply need to email me. I'll include my email address in the YouTube caption, and I'd be happy to send you a couple of page description of pharmacogenomics. All right, that's all for today. Thanks for getting this far, and all the best.